Good afternoon. I'm Amy Richardson, and I am the Community Health Outreach Director at Siloam Health. We're excited and honored to be here to share with you about our Community Health Worker program in particular. If you're not familiar with Siloam already, we have a vision to see whole person healthcare as a catalyst for the flourishing of a whole new Nashville. And so we know that to be a catalyst and to bring about change, we have to have that spirit of trust. And that's what our Community Health Worker program does, and I'll share a little bit more about it. Siloam, just as an overview, is a primary and specialty care clinic. We see about 5,000 patients a year. We also provide training through our Institute for Medical Nursing, Public Health, and PA students and pharmacy students. And then we also have a community health program that I lead that is really the public health arm of our organization. About 90% of our patients are born outside the U.S., coming from more than 80 countries and speaking more than 70 languages. So we deal a lot with cross-cultural care. And through our Community Health Worker program in particular, we're able to advance health equity with the priority of supporting mental and emotional health by providing individuals and families the support necessary to maintain positive mental well-being. So the purpose of the Community Health Worker program is to establish a culture of health, addressing the physical and mental well-being as well as social determinants of health amongst refugee and immigrant populations in Nashville. So I'll tell you a little bit of a taste of what that's like. We have some of our Bhutanese refugees. There's a group of elders, and the Bhutanese began to be resettled in about 2008. But the elders in their community are not working. Their adult children are out of the home working. Their grandchildren, often that live with them, are at school. So the Bhutanese elders have experienced a lot of loneliness and some depression symptoms at times. And then they've also experienced physical health changes since coming to the U.S. In the refugee camp and in their home country, they were walking everywhere they needed to go, involved in labor in the fields. They were farmers. And here, those things aren't happening, plus there's greater access to junk food and Coca-Cola, and they're embracing those, unfortunately. So our community health workers are members of the refugee and immigrant communities that they serve, and so they know both the linguistic but also the cultural aspects and are able to serve them well. So Hannah, one of our Bhutanese health workers, began health education classes with these elders, and she also does some one-on-one home visits to address physical, emotional, and social determinants. We use this community health worker model in 4 target communities: Burmese, Bhutanese, Hispanic, and Egyptian. So some of those are refugees and some are immigrants. If you're not familiar, community health workers are frontline public health workers who are trusted members of the community that they serve. And it's this trust that allows the community health workers to serve as a liaison between the health and social service community and their own community to better facilitate access and improve the quality of care and the cultural competence of the service delivery. They also teach prevention and promotion in relevant and engaging ways for their own communities. So we begin working in these 4 communities by administering a health assessment, and we identified these particular needs in the 4 communities. So you'll see that particularly the healthy emotions, stress reduction, and depression align with the community health improvement priority of supporting mental and emotional health. And we know that especially in immigrant and refugee communities, meeting basic needs like housing, employment, helping with insurance, and access to care, knowing how to navigate the health system, not only helps individuals and families improve their physical health, but it also relieves some of the stress and distraction that comes with not knowing how to do those things. We also know that our community health worker program promotes systems level change because we're working upstream, addressing health at the community level. We're training our community health workers who teach small groups of people and individuals, and then they go out and share with others in their community. And I have another story from that Bhutanese elders group. So Hannah, the health worker, had gone, and one of her lessons was on nutrition. And they were talking about healthy substitutes for the same food that they had been cooking before they came that's relatively healthy and full of vegetables. And so they talked about olive oil being a healthier substitute. Then, a few days later, Hannah went on a home visit to see a new client that she hadn't met before. And during the in-home assessment, this new woman was so excited to show Hannah the oil she had just bought, olive oil, that she had learned from a neighbor was a healthy choice. So for us, that was a great example of how the message is spreading. We don't have to reach them all, but we have to share it in ways that they can share in their own communities. We know that this upstream approach depends on cross-sector collaboration. So some of our initial key partners for the program were ethnic churches. Those are places in these 4 communities where trust already existed, and the messages that we could find people that were trusted in the community and ways of sharing that were trusted because that was already happening in those spaces. So the church partners continue to be one of our key places where we use for outreach and networking. But not everyone that's part of these 4 communities attend the church, so we also have looked for other ways to get involved through employment and neighborhoods and other ways to get members of the community involved. We also collaborate with other partners in town. So we've worked with MTA to do bus training since transportation is such a challenge for most of our patients and clients. And then partners like Alignment Nashville to do some health education to parents of school children in the school. So we have several different partners that we work with to share these messages. For the program in particular, we've identified 4 objectives. The SMART objectives are on your handout that I gave you, but those don't look as nice on a slide. Generally speaking, our 4 objectives are to promote health equity through workforce diversity. So we believe that our health workers, all members of these communities, are promoting equity when those that they serve recognize someone that looks like them in the health system. And then the health workers are also serving as that bridge, so not only educating their own community, but also educating the health and social service community about nuances and cultural aspects of those that they serve. And then objectives for the clients and patients themselves are to increase the navigation and utilization of the healthcare system, to promote social connectivity and the emotional well-being of those we serve, and then supporting emotions through improved nutrition and physical activity. Particularly in refugee and immigrant communities, we see a connection there. We hope to achieve these objectives through activities that are group health education classes, home visits and caseload management for one-on-one, and we use a system that is patient-centered and goal-directed when they do those home visits. Then the health workers are also serving as a connector, not only between the system and clients, but also when community members themselves find resources, they're able to share that with one another. And then the health workers themselves are attending group trainings and workforce development activities at Siloam. And I've found that that's been one of the most fun parts of the program for me personally, because some of the things that I've taken for granted as a skill I've learned just along the way, they don't necessarily have that background. So typing skills and organization skills are some of the things that we've worked on and seen a lot of improvement that have allowed them to do their job better and really equipped them when they decide to take future steps in the healthcare workforce too. As outcomes, we believe that we'll see a 75% increase improvement in 75% of the workforce development skills amongst our community health workers themselves. And then amongst patients and clients, 75% will report an increased health system utilization, 75% will maintain or improve their emotional well-being, and at least 50% will report improved diet and/or exercise as a result of our intervention. We know that this will advance health equity because we're reaching part of Nashville that isn't as much seen. So 1 in 8 Nashvillians is foreign born, but that's not necessarily where the health system is reaching, and we know there's some with the strongest needs. And we're able to do that in culturally relevant ways using a peer-to-peer model of the community health worker. As I mentioned earlier, our activities are patient-centered and goal-directed, and that helps promote health equity because the patients have a say in what's happening. We do have a monitoring and evaluation system set up, but we're also looking to improve that. So we have an agreement with the University of Pennsylvania's Impact Communities program to develop a stronger evaluation plan that will happen later this spring. So I can't report on that quite yet because we're improving some of the tracking systems that we currently use. But we do have an electronic data capture that's HIPAA compliant so that we're tracking all of our encounters. And then patients are using a roadmap to sort of identify goals and then work towards meeting them. We have weekly team meetings amongst our own team, and then our health workers are checking in with their clients on a weekly basis. And we're then able to assess milestones as we move throughout the program. This timeline is in your packet as well, but just as an overview, we have some work that I mentioned we're hoping to do before the grant starts, working with that evaluation planning. But then once we reach July, we've got 2 planned cohorts of caseload clients, those home visit clients that we'll see over the next year. And then on a monthly basis, we'll have those group health education classes running. Those series run anywhere from 8 to 16 weeks, depending on exactly what they're teaching. So we'll have pre and post tests along the way there. And then monthly, our community health workers continue to receive ongoing education about additional health topics, either that they encounter or that Siloam nurses have identified as a need that continues to be improved in our health workers. So we are requesting the $50,000 for the implementation fund. Most of that goes to our team for the salaries, but then we have some for our health workers going out into the community. That's where the travel comes from, as a lot of their work is based in the community, and then some supplies for meetings and trainings as well. And so to end, I just wanted to share this picture of, that's Hannah in the yellow shirt there, leading one of her group health education classes with the elders. And some of the successes that she has seen is that one day she was going on a home visit in the neighborhood where this class happened, and she saw one of the elderly ladies out getting her meeting her goal of 30 minutes a day of exercise. And so Hannah saw her from the car. She was out there getting her walk in for the day. And the elders especially have found this really fun, that they can walk, that they're able to walk. There are sidewalks in this neighborhood, and so they're excited to meet that goal. And then Hannah has stopped teaching the class. She just checks in with this group once a month now, but the elders are continuing to meet with one another. So that loneliness piece and that mental health piece is something that they're able to continue. Sometimes they walk together, or they meet together to share a healthy recipe, or sometimes just to talk about their grandkids. But they're still meeting together in between. So we're able to really advance the health equity amongst refugee and immigrant communities by serving as this catalyst, because we have the trust built with the community. Thank you very much.